So once again, welcoming everyone, all the attendees for the session of Eye Diagnostic. Myself, Dr. Indumathy from Coimbatore branch. I'm a general ophthalmologist with keen interest on refractive surgery, counseling and conversions. Today, the speaker is Dr. Abha Wadhawan, a beauty with brains. She's not only an phaco-refractive surgeon, but also a certified surgeon from Aesthetics Clinic of India. She has done her MBBS from Government Medical College of Jammu, her DNB and Cornell Fellowship from HP Desai Hospital, Pune. She also has to her credit being a NABH assessor. Our panelist for the day needs no introduction. One of the rising stars of Dr. Agarwal Eye Hospital, TTK Road Center of Excellence, Queen of PDEC and all type of corneal transplant surgeries, Medical Director of Dr. Agarwal's Eye Bank, and Academic Director of DNBN Fellowship Program. Yes, none other than Dr. Preethi Naveen. So today the topic seems to be a simple, but it's a complicated one actually. It's a simple complaint that we see in our day-to-day practice, dry eye, but which needs a thorough evaluation. Unless we diagnose the cause correctly, we'll not be able to treat the patient satisfactorily. So now I think Dr. Abha will take the session. So over to Dr. Abha for your presentation.
Thank you for your kind introduction, ma'am. And I'm really happy to be here on this, to be speaking on the topic of dry eye, very dear to me. And thank you very much, Dr. Ashvin and Dr. Preethi Naveen, Dr. Preethi S, for giving me this opportunity today. So without any further ado, I'd like to start with the diagnostic and the treatment rationale of a dry eye. My topic would be divided in definition of the dry eye, followed by the clinical evaluation and the 6 steps or the tasks for detecting and treating a dry eye patient from the beginning till the end. And after that, the treatment part will be followed up. That should be the end of it. So starting with the definition of a dry eye, we all know it's a multifactorial disease of corneal ocular surface. It's characterized by an unstable tear film, also known as loss of tear film homeostasis. Along with that, we have ocular symptoms in which hyperosmolarity, ocular surface inflammation, and neurosensory abnormalities play an etiological role. But why dry eye is so important? It is because of the pain and the irritative symptoms that it causes and the decrease of the visual performance, affecting the productivity of a person at the workplace to around 2 to 3 times more. The discomfort caused by the dry eye is considered as equivalent to that caused by a severe angina or a person undergoing weekly dialysis. So we can understand the amount of the global economic burden a dry eye causes. The various symptoms are as follows. As we all know, dry eye and gritty sensation, temporary blurry and foggy visions. And now we come to the 6 tasks which have been given by the DUCE 2 study, which starts from the beginning. So the first step would be to offer the patient certain triaging questions. These triaging questions are given to find out and confirm whether the person is actually having dry eye symptoms or we are dealing with a masquerader of the dry eye. Second would be risk factor analysis. Third would be screening questionnaire. Fourth is a tear film homeostasis marker detection and subtype classification with the various diagnostic procedures. And the final would be the stepwise management or the treatment part. Hence, these are the 6 steps in which you'll be following, starting with the very first one, that is the triaging questions. The triaging questions that we have to ask the patient the very first moment the patient turns up to us is, how severe is your discomfort? Do you have mouth dryness, which is suggestive of Sjogren syndrome? How long have the symptoms been? Because we said that the symptoms increase as the time progresses. Is there a contact lens usage? Is your vision gets affected or gets clear on blinking? Because a blinking would improve the vision in a dry eye and deteriorate in allergic conjunctivitis or a masquerader. And are the symptoms of redness worse in one eye or it's bilateral, because dry eye is generally a bilateral disease. And do the eyes itch, and is there crusting of the lid margins, especially in the morning time? And if it is such a condition is existing, then it could be a lid margin disorder. And the patient is having any systemic disorder for which he's taking treatment that could be responsible also for causing the dryness in the eye. The second is the risk factor analysis. It is important because The things that we can control or modify should be modified, and things which can't should be told to the patient that you have to live with them. And but the best we can do for you is the treatment in the following manner. So various non-modifiable risk factors would include aging, the gender, the race of the person, the meibomian gland dysfunction. Irrespective of having so many treatments, still meibomian gland dysfunction is considered as a non-modifiable risk factor. Various connective tissue disorders and Sjogren's syndrome, these are non-modifiable risk factors. Certain modifiable factors would be the contact lens wear, the environment like smoking or the sick building syndrome, androgen deficiency, estrogen replacement, HRT treatment that the patient is taking. These are the risk factors which we can modify to the benefit of the patient. Then we have a screening questionnaire. Now, the screening questionnaire, by large, we use is a DEQ5 and the OSDI score. The DEQ5 is a simpler one, and the score positive for ocular symptoms would be anything beyond 6. In OSDI, it would be 13. Why is it important? Because the patient has to have ocular symptoms to be labeled as a dry eye patient. And the scoring is important because we can determine whether the patient is getting better or not with the treatment that we are giving. And it is also helpful in various research purposes. The Now looking at the clinical examination before we start with the homeostasis breakdown detection of the tear film, the very first would be in this gentleman that we are seeing, there is presence of brow ptosis, there is presence of dermatocalcis, is orbital fat prolapse in the lower lid margin, and there is frontalis overaction. Now, why am I showing this picture? Is because this patient was being treated as a dry eye patient for since a long time, whereas it is not just the dry eye which is playing the part in this case. Because of the lack of apposition of the lower lid margin with the globe, because of the orbital fat prolapse, this patient is not having the apposition of the puncti with the tear lake, hence is having epiphora. The dermatocalcis itself is responsible for the excessive effort that the patient is doing in order to lift his eyelid. So by the time it is evening, the patient is not only fatigued because of dry eye, probable dry eye, but also because of the lid margin or the lid disorders. So we need to evaluate the patient from outside to inside in a total, so that we know what are we dealing with, because every time it's not going to be dry eye, there could be other things also. Next, we come to the clinical examination, in which we have to follow the principle of LPP. The L would be to look. What do we have to look at? We have to look at the base of the lashes first, from outside to interior. The first would be to detect whether there's a presence of anterior blepharitis in the patient, the lid position is fine or not, is it getting opposed with the globe, what is the tear meniscus, it is reduced or it is there or it is not there, is there a presence of conjunctival calluses, which is the presence of a conjunctival fold. The second would be lifting. So when we lift the eyelid, we upturn, we need to see, look for the papillae, we need to look for the lid viper epitheliopathy, which picks up the stain on fluorescein. We need to look for the presence of lacrimal gland prolapse. We need to check for whether lacrimal gland is normal shape or is it enlarged or it is atrophied. And pulling, by pulling we have to pull the upper eyelid margin, the upper eyelid, to check for whether it is laxed, is there for floppy eyelid syndrome, and the lower eyelid has to be pulled in order to see whether the horizontal laxity exists, because it will directly affect the lacrimal pump. And the last would be to push, and in the pushing we are basically pushing the lower lid margin to check for meibomian gland secretions, their quantity and their quality. So once the outside clinical examination is done, one very important thing that we need to do is the lacrimal gland. We can check the lacrimal gland's production or secretion of the tears by lifting up of the upper eyelid by the procedure called as DATS, that is dynamic assessment of tear secretion, in which it's a very simple procedure. We just touch the lacrimal gland with the fluorescein strip, and we wait for it, just in this similar manner like a Siedel's test. We wait to see whether there is production of the tears or not. So we will see for the shape of the lacrimal gland. We look for the tear flow. It should normally be 1.05 microliter. Just by looking, we'll not be able to understand the amount of the secretion, but we'll get an idea. The second would be the number of ductules. The normal ductules should be at least 3 to 5 per gland. and the time lag should be less than 1 second. That means it should be an instant flow, which is washing away the fluorescein that we have touched with the lacrimal gland. Here we can see that in a normal gland, lacrimal gland, we are having a convex gland which is having a good vasculature, and the number of ductules are 3 to 5, and there is no subconjunctival fibrosis, and the secretion rate is seen to be markedly reduced in a Sjogren syndrome as well as an aqueous deficiency dry eye. So this is one of the tests that we can do very simply on the clinical examination on a slit lamp. Now, coming for the tear homeostasis marker, the very first would be an invasive tear breakup time that we can do on the slit lamp. This involves touching the ocular surface with a fluorescein strip. Now, tear film breakup patterns. This was given by the Asian Dry Eye Society. This is having 5 different patterns in which the tear film can break up. The first one is the area break. The area break where there is no movement at all of the tear film, that is suggestive of a severe aqueous deficiency dry eye. The second is a spot break. The spot break and the dimple break. The spot break is something that occurs even before the lid margin or the entire opening of the eye takes place. Even before that, this formation of small oval spots, generally on the superior part of the cornea. This is suggestive of decreased wettability. The line break is suggestive of a mild, moderate aqueous deficiency, and a dimple break would be seen as straight, streaky lines in the center of the cornea, suggestive of moderate decrease of wettability of the tear film. And a random break would be the moment the tear film is formed after a blink, there is a quick break and the random spots appear all over the cornea. This could be because of reduced wettability also, and by large because of the evaporative dry eye. The second homeostasis marker would be a tear film osmolarity checkup that is done with the help of a tear lab test. In this, the instrument is used to pick up the tear film, and it tells you about the osmolarity present in the tears. Normally, it should be less than 308 milliosmoles. Anything more than that, or an inter between the two eyes, any variation beyond 8 milliosmoles will be considered as a positive marker for a dry eye. The third homeostasis marker is the ocular surface stain, in which we are having corneal, it will be considered positive if there is presence of more than 5 corneal spots of the staining and more than 9 spots on the conjunctiva, and the lid margin stain pick up at least 2 millimeter in the length and more than 25% of the width of the lid margin getting stained with taking up the stain with the fluorescein. So this is the manner in which we can classify the ocular staining, divide the eye, and we can measure the amount of per quadrant staining, so that when we treat the patient, we can not only detect or tell the level of the staining severity, but also help in checking whether the patient is getting better with the ocular surface stain. So the pathophysiology of a dry eye involves neurosensory abnormalities, tear film instability, tear film hyperosmolarity, and ocular surface inflammation. So in the similar manner, we'll be detecting and going for diagnostic tests also. So the tear film detection with the diagnostic test, first homeostasis marker as explained, is a non-invasive breakup time. This can be done with the ocular keratograph, or it also can be done by ocular surface analyzer, in which the appearance of the dry spot is noted, the time at which it is appearing is noted, and that can help us in detecting the stability of the tear film. So this is about an ocular keratograph. Ocular keratograph 5M is not only tells us about the topography, which is placido based, but it also talks about the redness score. So we can also detect the congestion levels or the redness levels and compare it with the slides that we have. It tells us about the non-invasive breakup time also. It also tells us about the non-invasive breakup time, the tear meniscus height, the mebography, and certain corneal staining images can also be picked up. The ocular surface analyzer is the latest and a very comprehensive diagnostic modality, which helps us in not only detecting the lipid layer thickness, the tear meniscus height, the non-invasive breakup time, mebograph, redness score, also gives idea about the pupillometry, and OSA plus, which is the latest, would also tell us about the blink rates and whether they are complete or partial blinks. And it also gives a three-dimensional meibography picture of the glands and also detects tear meniscus height at multiple points of a blink. So this is the eye draw ocular surface OSA report. This, as we can see, it's just like a traffic signal, the green, yellow, and the red. So anything which is going in the danger zone will be shown in a red zone. Anything which is on the borderline will be shown by the yellow, and by the green we can see the normal values. So in one go, we can detect what exactly the problem is existing with the patient's tear film, and we will be able to diagnose whether he's having aqueous deficiency or evaporative or a mixture of the two. This is the LipiView oblique Lipi scan, which not only helps in detecting the LLT, that is the lipid layer thickness. Normally, it should be 100 nanometer and above. Anything between 65 to 100 is still moderate deficiency. Anything below 65 nanometer would be considered as a lipid deficiency or a evaporative dry eye. Besides this, it also gives us an idea about the blinks. The first 20 seconds, how many blinks are taking place and how many of those blinks are partial and how many of those blinks are complete. Why is it important? We'll be discussing that in a while. Now, detecting the tear film volume. Tear film volume can be easily detected by the Shermer's, which tells us about the tear formation within 5 minutes. As we all know, the minimum possible reading should be 10 millimeter and above. And but this is not a very sensitive. It's sensitive, but not a very specific test. So the other test available would be anterior segment OCT as shown on the left side. This helps in detecting the tear meniscus height, and we also have the tear strip meniscometry. This will give us an idea about the tear volume, and this directly correlates, the TMH directly correlates with the probability of having aqueous deficiency dry eye. This can be incorporated in a slit lamp examination very easily. This is tear lab we've already discussed. It will tell us about the hyperosmolarity levels of the tear film, as it is very important part of the definition of the due to study given by the dry eye. So if we can incorporate it in our OPD, it will be really helpful. This is the MMP9 test or the RPR detection. This helps in detecting the presence of MMP9. This is the matrix metalloproteinase enzyme, and it's generally seen in said to be raised in the tear film inflammation. So whenever there will be an inflammation in the tear film detection, we can start the patient with topical steroids or with cyclosporin or with tacrolimus. So this is helpful in making our diagnosis and treatment easier. This is the normal picture of a normal meibomian glands, where the upper eyelid is having roughly around 25 to 40. The length is around 5.5 millimeter. The lower lids are having 20 to 30 glands, which are around 22 millimeter in the length. And any abnormality in the structure can be detected by the meibography. This is a picture, ma'am. Besides just having a meibography, in case if we don't have, we can look at the structural abnormalities of the meibomian glands with the help of an autorefractometer also. NCT, IOL master, fundus camera, or a specular microscopy also helps us in detecting the glands by retroillumination. This is a OSA plus that we discussed earlier. This is giving a three-dimensional model appearance of the meibography. So it will help us in detecting not only the atrophy of the glands, but collapse of the glands and any kind of an obstruction of the glands also. This is the Meibo scale, which helps in, it's a very easy thing. We can see the type of glands that we are seeing on the diagnostic modality we're using, and we can compare it with the pictures given and hence define what degree of the meibomian gland loss is there. These are the various morphological patterns in which the meibomian glands can undergo destruction, which is a normal meibomian gland, which should be like the keys of a piano. So whenever they are hooked or they're overlapping and they're extremely short and thick and some dropouts of the glands are seen, these will be suggestive of a meibomian gland dysfunction. This is important because we need to know how many glands are available for us. Because if we don't have any glands at all, no matter whatever expression, no matter whatever leafy flow, whatever we do, it's not going to make any difference to the patient because there's no factory for the production of the oil gland. So once we have gotten enough information through our clinical examination and diagnostic procedures, this is the chart that we can follow, where Shermer's is normal, lipid is normal, tear breakup is normal, diagnosis is normal. We need not treat this patient. A patient who's having normal tear breakup time and Shermer's is decreased, lipid layer is normal. This would be a preclinical ADT, that is aqueous deficiency dry eye, and so and so forth. So a tear breakup time is most important thing. If the tear breakup time is normal, it is always be considered as a preclinical, and the treatment would be dependent on the presence or the absence of certain symptoms or the signs. Whereas if we have tear breakup time which is shorter, and which is generally seen in allergic conjunctivitis or in the younger patient, there the treatment modality would be different. Now, coming to the treatment rationale, when we talk in the same pattern, the tear film stability will be seen first. Tear film stability is lost whenever we are having any one of the components of the tear film not being present in the right quantity, either in excess or in less. So, whenever we have an increased evaporation, which can be seen because of the lack of lipid layer, we need to give the patient certain liposomal sprays and oils in order to thicken up the lipid layer. Besides that, doing lipiflow and hot fermentation and other omega fatty acid supplementations. If there is aqueous deficiency and muco-aqueous deficiency, in those cases, as we have already seen by the clinical examination, by the various patterns of breakup, and by the tear meniscus height, and by the various lacrimal gland morphology, we should be able to give them certain viscosity enhancing agent, which not only increases the retention time of the lubricant on the ocular surface, but also prevents the friction between the lid margin and the ocular surface. Now we need osmoprotectants as well, and we'll be explaining coming to that in a while, why the osmoprotectants are required, so that the epithelial cells do not undergo damage because of hyperosmolarity. And then we have ocular surface apoptosis, which is a part of the inflammation, and because of excessive mechanical friction, this can be taken care of by providing topical vitamin A ointments, and by giving PRP eye drops or autologous serum eye drops, and certain sodium hyaluronate and carboxymethyl cellulose derivatives as supplements. Ocular surface inflammation can be detected either by congestion of the tear film, congestion in the conjunctiva, or by the presence of MMP9 positive. In these cases, we are treating them with steroids and other cyclosporins, immunomodulation. So the second is the hyperosmolarity in the pathophysiology pattern. What exactly happens is that whenever the hyperosmolarity is there, it leads to a osmotic pull. Now, the fluid from the epithelial cells will go out into the extracellular environment, causing crenation of the cells. Once the crenation takes place, the cell starts becoming a leaky body. When the leaky body is it becomes a leaky body, it behaves more like an antigen. And once the epithelial cells turn into antigens, they become the source of inflammation, and the inflammation starts the immunopathological cycle. So whether it is hypertonic outside ECF or hypotonic, it will cause the cell to swell up and ultimately will cause apoptosis to the cell. Hence, there is a requirement of the presence of osmoprotectants in various lubricants. Now, the natural bioprotectors like the trehalose, L-carnitine, all these will help in stabilizing the lipid membrane and preventing the osmotic pressure inside and outside this epithelial cell, in order to avoid the crenation of the cell and prevent the exposure to desiccation stress. These are other osmoprotectants available like the sorbitol, L-erythritol, L-carnitine. Now, once the leaky body has formed, which becomes the antigen for the ocular surface, now there are two pathways involved in immunopathogenesis of a dry eye. One is innate and the other is adaptive. We need to know this because we need to know why are we putting an eye drop and what is the reason for doing it. So as soon as the antigen is produced, we have a non-specific cytokine storm on the ocular surface, in which various pro-inflammatory cytokines are released. These pro-inflammatory cytokines, which are interleukin 1, interleukin 6, tumor necrosis factor alpha, and the production of matrix metalloproteinase 9, all these lead to the immature antigen presenting cells, which are already present on the ocular surface, to come and engulf the antigen. So once the antigen is engulfed, it starts processing that in the immature antigen presenting cells. It picks a part of the antigen, puts it out on the cell surface, becomes a MHC class 2 complex. And once the MHC class 2 complex is present, it attracts further cytokines to come and help in its maturation. Once the antigen presenting cell becomes completely mature, it leaves the ocular surface and enters into the afferent pathway of the adaptive response by utilizing CCR7. Once it enters into the afferent pathway of the lymphatic cells, there is upregulation of ICAM, intercellular adhesion molecules, through which this molecule is able to attach and reach into the lymph node. In the lymph node, it recruits and converts TH0, the helper T cells, into TH1 and TH17. They get back to the ocular surface where they release various interferon gamma, and they also release matrix metalloproteinases. So once this entire cycle is established, it becomes a constant vicious cycle, which the dry eye keeps increasing because it gets involved in the vicious cycle. So we need to step in, and any of the places, like it could be innate or the adaptive, in whichever medical modality we have, in order to stop it from getting into further apoptosis and breakdown of the epithelial cell barriers. So this is a mechanism of action of various immunomodulatory eye drops, where the first phase is the initiation, the second is amplification, third recruitment and damage in cell. So the steroids, corticosteroids, to cut it short, the corticosteroids is what will help in preventing the formation of pro-inflammatory cytokines, the very first step, very first stage. The second is the amplification, where the zedra or the leafetigrast molecule will act. It does not allow immature antigen presenting cells to attach itself with the ICAM expressed by the endothelial cells in the vasculature. So it does not allow the mature antigen presenting cells to get into the lymph node, and within the lymph node, it does not allow it to produce further recruitment of TH1 and TH17 helper T cells. So this is how it acts. So it acts on the afferent as well as efferent pathway of the adaptive immunity. The cyclosporin has an intracellular mechanism through which it doesn't allow the amplification of the T cells and production of the cytokines by the T cells. Therefore, we always require a corticosteroid along with any of these immunomodulators, because once the T cell has been activated, it cannot be switched off. So whatever is on will cause the damage. There comes the role of a corticosteroids. Then immunomodulation can also be brought out by autologous serums and platelet-rich plasma. Why is it helpful? Because of the presence of certain growth factors, which are epitheliotropic. They help in anti-apoptotic. They have an anti-apoptotic nature. The production of various immunoglobulins also have anti-apoptotic activity. Fibronectin, which gets stepped up whenever there is apoptosis, it helps in forming a scaffold for the cell migration. And certain cytokines and lysozymes have anti-inflammatory action, and certain vitamins are also present which help in maturation of the epithelium. So what we have right now are the steroid eye drops, cyclosporin A, levetiracetam, and blood biologicals for topical immunomodulation, whereas the newer drugs around the corner are these. I would just want to touch them in brief. The first is AR15512. This works on the cold thermoreceptor. So whenever we are in cold, there is excessive production of mucin in the eye. So this kind of activates this receptor for better production of the tear film. RGN259, these are all molecule names. This help in promoting cell migration and prevents the apoptosis. Visomitin, it is an anti-aging type of a eye drop which prevents the oxidative stress on the lacrimal gland. Hence, it would be, it's still in the clinical trials, it will help in preventing the development of dry eye. AZR-MD will be a keratolytic ophthalmic solution which can be used for prevention of obstructive type of MGD. Lacripep is lacritin, and this lacritin is generally having pro-secretory properties, so it will help in increased production by the lacrimal gland. GLK301 as pilocarpine, as we know, it helps in improving secretion. Tenfornetcept would be a tumor necrosis factor alpha inhibitor, hence it will prevent the inflammation. And senagermin is something which will help in neurotrophic keratitis by improving the formation, improving the nerve structure and preventing the formation of various. We have IPL, intense pulse light therapy for meibomian gland dysfunction. It works by two mechanisms. The first part, which involves exposure of the ocular surface to 500 to 1200 nanometer light, is basically to have an anti-inflammatory activity. So it is absorbed by the hemoglobin in the telangiectatic vessels, where it causes the clotting of the blood and breakdown of the blood vessels. Hence, the inflammatory mediators are not able to reach the ocular surface. So, this is the first mechanism. Also, it leads to upregulation of collagen synthesis and kills the demodex if present. It also causes suppression of matrix metalloproteinase. In this manner, it acts on the innate immunity pathway. The second mechanism is generally which is brought about by the trigeminal nerve stimulation. In this OPE, that is optimum light, the therapy which is given, this helps in stimulating the trigeminal nerves, the ophthalmic and the maxillary division, which get into the midbrain, and from there they bring about impulses for better secretion through the lacrimal gland as well as the meibomian gland. Hence, in my opinion, the IPL is not only helpful in evaporative dry eye, but it is of certain help in aqueous deficiency dry eye as well. These are the diagram or the pictures of certain types of IPLs that we are having, like Optima, the eye light by the Topcon, and the EI by the Eastwind. This is the LEPI flow. This is basically working on the vector thermal pulsations. It is generally used for obstructive kind of meibomian gland dysfunction, where a heat is produced and there's a mechanical milking action through which the meibomian gland secretion comes out onto the ocular surface, and hence the obstruction is open and the normal secretion from the meibomian gland start. Now we also have neurosensory abnormalities as the etiological part of the dry eye. In this, we are having reduction in the subbasal bowman plexus of the nerve. This can be improved by various neuro nerve growth factors that are available in the autologous serum. Thus, any patient who is having decrease in the corneal sensitivity or neurotrophic keratitis, that can be helped by giving PRP, eye drops, or autologous serum. It is seen that at the end of 4 to 6 months, there is an improvement of the density of the nerve fibers. Various alternative therapies for the treatment of the dry eye would be lacrimal gland hypofunction, in which we can inject the lacrimal gland with PRP, with certain stem cells, and we can also have transcutaneous nerve stimulation, which improves the secretion from the lacrimal gland. And we also have improvement in the secretion by the lacrimal gland through transcranial TMS, transcranial magnetic stimulation. And the nerve injury, if caused, can if there's a type of a neuropathic pain, besides giving patient gabapentin, we can also diagnose whether it's a central or a peripheral and treat them accordingly. If it is a peripheral neuropathic pain, it can be treated with amniotic membrane. And if it is a central, certain nerve blocks and botulinum toxin and transcutaneous nerve stimulations can be done. Meibomian gland dysfunction, we are giving eyelid massages and IPL and topical antibiotics. Interestingly, Manuka honey is also something which can be tried. And the ocular surface inflammation can be prevented with trehalose and IPL. Thank you.